Well, hello, everyone. Welcome to another edition of the Texas Public Policy Foundation's series of video conferences where we talk about the issues of the day. In today's broadcast, we're going to be talking about data and the public health response to the coronavirus. There certainly has been quite a bit of controversy and quite a bit of discussion about exactly the quality of the data that we're getting and how that shapes the public health response, how that shapes public perception, as well as media perception about the threat from the coronavirus, from COVID-19, about the best way to respond to it. And I'm really happy that today we are joined by Dr. Held, who has been really following the coronavirus pandemic from the beginning. Dr. Held, thank you for joining us. And as we start, could you tell our listening audience, our viewing audience, just a bit about yourself, about your practice, and how you came to be really interested in the current response to the coronavirus pandemic?
Thank you so much for having me, Chuck, and I appreciate this forum to discuss this important issue. So I'm a ophthalmologist and ophthalmic surgeon from San Antonio, Texas. Went to the University of Texas at Austin, went to medical school, and did all my training here in San Antonio. So I have been a physician in Texas for over 25 years. And as a result, I feel that it's my obligation as a physician to know what's going on, particularly at the time of a pandemic. I'm currently president of a group called the Association of American Physicians and Surgeons, and I've been involved in healthcare policy for the last 12 years at many levels. And so it was incumbent upon me to, when you hear, oh my goodness, there's going to be a pandemic, to get engaged and say, what can we do? What is this? How is this going to affect my patients, my community, my family? And how are we going to treat this? How are we going to beat it? And that's what we do as Hippocratic physicians that honor the Hippocratic Oath, and that it is our calling and our duty to do what's best for each individual patient.
So as an ophthalmologist, it must have been very interesting to you. As I recall, wasn't it an ophthalmologist in Wuhan, China, that was one of the very first people who really started to connect the dots and noticed that there was a certain condition that was presenting with pneumonia-like symptoms? And given that China, of course, was the epicenter of the SARS virus back in the early 2000s, I think, as I recall, this ophthalmologist started to sound the alarm. What happened to that ophthalmologist? And did you notice that right off the bat, given that you as well are an ophthalmologist?
I did. And, before you can become an ophthalmologist, you are a physician. You graduate from medical school, you do an internship in internal medicine or general surgery, and you're licensed by the state of Texas. And then you go on and do your specialty training in surgery. So you have that underbelly of medicine should something happen like a pandemic. So immediately I heard about the ophthalmologist from China through our ophthalmology connections, and then just trying to study about the pandemic at large. And it was interesting because at the time, this whistleblower, quite bright physician, was saying something's going on. And what's interesting is that physician was tested on numerous occasions and was negative for the COVID-19 virus. But then finally, at the end, when he did turn positive, it was just a matter of a few days before he died. And he was on the front lines of taking care of patients. So we knew this was something very, very serious.
So staying with China for just a moment longer, it was my understanding that as the Chinese officials began to get a handle as to what exactly it was they were dealing with, they instituted a pretty draconian travel ban on Wuhan and on domestic travel. But at the same time, they were telling the United Nations World Health Organization, as well as internationally, hey, it's okay to have international flights in and out of China. It would be somehow bigoted to shut down travel to China. Would you say that that's inconsistent? What was going on? Does the People's Republic of China, do they bear any responsibility for the worldwide damage that we've seen?
Well, I would certainly think so, because number one, if there is a virus that is a threat to the people of the world, it is within your moral code to let people know. And it seems that it was very duplicitous on their part to have two different, one way that they were going to behave from a public health standpoint for themselves, and another way that they were going to do it for others. So yes, I do believe that China does bear responsibility for that, and through the World Health Organization. And I think that people need to really, going back and analyzing this to prevent, because you don't want to repeat the errors of the past into the future. They need to go back and look at, how did this happen? And if you are going to have a virus, whether or not this was made in the lab in Wuhan and came out of the lab, but if you're going to be doing any sort of experimentation with lethal organisms, then there's some sort of an obligation, and that if that organism gets out into the community accidentally or for whatever reason, yes, someone bears responsibility for that, and we need to have safeguards for that.
So looking at the Centers for Disease Control this morning, the current data that they have on excess deaths, which is really perhaps from a statistical standpoint, the most accurate way to see just how hard this virus has hit our nation. If you go back to the 1st of February to present, with the understanding, of course, that the last few weeks, it takes a while for that data to trickle up from the counties and the states into the CDC and be properly accounted for. But it looks like so far we've seen approximately 107% of the expected deaths from February 1st to present. And that equates to about 139,000 deaths that they've estimated to be attributed to the virus. But interestingly enough, another 39,000 people in excess who died from other causes. Could you explain to our viewers how it is that during a pandemic, when people aren't driving around, right, there's presumably fewer auto accidents because we're less mobile, how is it that we get 39,000 more deaths in the last, since February 1st from other causes? What's driving that?
Well, the main causes of the excess deaths that are non-COVID related, that are actually ones that are caused from the lockdown and from not being able to get the care that you need, are really in two major categories. Number one, cancer deaths look to be increased because people that would have been going in for routine care would have had early diagnosis. During the period from about March 19th to about May 7th, we were not allowed to do anything but emergent cases surgically or to see patients. So there is a large percentage of patients in Texas and then across the country who delayed care or went without care. One, because we were not doing it under the premise of reserving extra bed capacity for potential COVID cases, and also because of a great amount of fear. People were afraid to go to the doctor. They were told not to go to the doctor, so they delayed care. But I think then what's very, very sad on top of that are the increased deaths that we know we have seen from suicide, from alcohol abuse, from drug overdose, from abandonment and abuse in the home. And there's some estimations that may attribute to over 40,000 patients. So when we look at numbers, this data is so important for us to figure out what we're dealing with as physicians. We need to make sure that the data is meaningful, not a means of manipulation. And when you look at the numbers, you're talking about the death rate, and the fatality rate. We also have to look at when are those deaths occurring. And an interesting place to go to look at some of the statistical analysis of this is if you go on Twitter, and there is an account called The Ethical Skeptic, and there's some very, very interesting statistical analysis there that is very, very honest, and it looks at the CDC numbers, it looks at the lag of reporting, and it compares them to counties. You can even look at each individual county, and that is extremely important to look what's going on at the local level, because if you take out, you need to be able to compare apples to apples. When are these deaths occurring versus when are the deaths being reported? So for example, if I look at Bexar County and if we look at Texas, There's actually been a delay of a couple days now that they said they're having to kind of fix a glitch in the reporting that inadvertently reported about 270 or something excess deaths. So our number, if you saw that, you would think, oh my gosh, I'm afraid to come out. I'd go back in the panic mode, back in the fear mode. But what's really happening is, were those real deaths? Were those COVID deaths? We talk about dying with a COVID-related death. And when did those deaths occur? Are those a reporting error? Are those deaths that they just gone back and attributed to COVID that maybe happened a few months ago? So tying back to what you were saying, 107% excess deaths, with a lot of them, maybe a third coming from non-COVID related deaths. Where are we in reality? If you look at the numbers, it looks like maybe the peak was at about 141%, and that was back in April, whereas now we're way back down and almost to normal and really at or below what would be considered the epidemic line. So numbers are very, very important where we report them and what they're representing.
So I know that 2020 is hindsight, which I suppose is appropriate given your medical profession. I'll have to talk to you about my eyesight afterwards and see if you can hook me up. So the question that I have is regarding both politicians and public health officials that were very concerned, again, partially due to the misinformation, the lies that we were getting out of the People's Republic of China, but they were very concerned that this virus would get very quickly out of hand and that we would see our medical system become overwhelmed. And certainly it got very, very close in New York, right? They deployed significant federal assets that in the end treated very, very few people, and in some cases none at all. But tell me about how that affected medical bandwidth. How did that affect hospitals when elective procedures were shut down? As far as both the hospital's bottom line and their ability to keep medical professionals employed. Could you walk our viewers through what happened, even though necessarily that wasn't the intent?
Absolutely. This is very, very critical. And as Americans, we are extremely compassionate and we appreciate life and we do not want to lose a single life. So when we heard about this pandemic coming and we didn't know what to expect, we very, very willingly embraced the 2 weeks of flatten the curve. And it was hitting New York horrifically. New York, right in New York City, we have 29.6 million people in the entire state of Texas. They have millions in a very, very small area geographically in New York with people living in very, very close proximity. And so with a virus that we're being told is extremely contagious and also that hits minority populations, patients at risk, diabetics, obese patients, particularly elderly patients, we said, oh my goodness, we better help New York. So what happened here in Texas is that we went into our initial 2-week flatten the curve shutdown before we really had any cases. I think we had our first cases reported. We had very, very few cases at all across Texas, maybe 26 by mid to late March when we went into full-blown shutdown mode. So during that period of time, as you said, resources, ventilators, resources. We didn't know that you didn't really need that many ventilators at that time, but everything was set to take care of New York. So as a result, here in Texas, we were not allowed to operate or do any elective procedures, things that were considered non-emergent. So for example, I did not go to the operating room I operated March 19th, and then I didn't get back to the operating room until May 7th. That's the longest that I haven't operated in my professional career. And so when you take this across all surgical specialties, you can see and all across the state and the thousands of surgeons, you can see that contributes to a large number of patients going without care, their conditions getting worse. And as a little side note, I might say that there were some errors that occurred there where the way that Governor Abbott's executive order was interpreted and enforced by the Texas Medical Board. I know of colleagues that are being investigated for operating during that period of time when we were told not to operate, even when it was on cases that the surgeon considered were indeed emergent and urgent cases to be done. So, we bear a little blame for ourselves. And in this situation, this was done so that we could increase hospital capacity for the surge of COVID-19 that we felt was going to come. We didn't really know. And hospitals, inpatient surgery ORs, and then also some surgical procedures are done in operating rooms affiliated with the hospital. And those cases are a large source of income to that hospital. So when suddenly you stop a large source of income to a hospital, and also you restrict patients from coming in, you not only have patients now that are developing worse problems and making a bigger problem. Now we have a backlog of patients to add to the potential COVID patients coming, but now we have bankrupt hospitals. So the hospitals have to look at their bottom line. And so the sorts of things that we saw happening were, for example, our daily nursing schedule or our PRN, where we used to have a group of nurses that would be on standby to come in if there was an overflow. Those nurses were let go. There were nurses and staff that were furloughed in order to try to keep the hospitals going. In my situation, I went in every day. I mean, there were days where I maybe saw 2 or 3 patients, but I was on call for 2 of the weeks during the period of time. And I can't just shut my doors and say, you're going blind or you have something, just get over it. I'll see you in 3 months. So just as an individual physician, I operated under almost a 2-month period with no income whatsoever for myself, trying not to lay off my staff, trying to take care of very few patients, but going very, very significantly in the red. And that's just me and one person in one practice. So when you expand that to the hospitals, all of a sudden we come into May and we have less staffed beds because the hospitals and OR sat empty, compounded by the fact that now we have more sick patients. And we haven't even seen our COVID wave yet. Then here comes our COVID wave. So something happened in mid-June that we really need to look at. And one of the things that happened was, again, tying to back what we're talking about to data. We do have way more cases, but how do we know how bad it's going to be? Because the definition of cases changed. And there was a good synopsis of this up at the Collin County Commissioner's Court. Judge Kris Held was really brilliant in pointing out the fact in Collin County, and this ties back to what we talked about earlier about how important the local levels are in the counties, that they changed the definition of what constitutes a COVID case. So, if you're going to see what's happening to cases, you have to have transparency. You have to have continuity of what defines a case. And suddenly in April, there's a group called the Council of State and Territorial Epidemiologists, and they came up with new definitions for COVID cases. This was adopted by the CDC, and then the CDC came to the state of Texas, so that the DSHS then adopted these new definitions, and then county by county, the counties had to adopt them. And these cases included, and there's a nice synopsis of that meeting from about the 15-minute to about the 59-minute mark. If you want to hear it, it's a very, very eloquent description of the way that one PCR positive test COVID case through contact tracing and epidemiological connections can result in 17 cases being reported, theoretically, 17 different scenarios from one person testing positive. And that can be as little as a patient in a at-risk county. Say, for example, you were in Bexar County and you happen to work with an employee who tested positive and you're around that employee, and then you self-report a fever. You can be reported as a presumptive or presumed COVID case. So when we looked, example, in San Antonio and Bexar County, some of our numbers at the time when they were going up were including these presumed cases, and we had to take some steps to break those cases out because we need our data to be meaningful. So then we look at our hospitalizations, and the hospitalizations have to be meaningful. What constitutes a COVID hospitalization? Well, about this same time, You could have some of the hospitals and some of the bigger hospital systems started testing every single patient that came in. So for example, you could have a patient coming in to deliver a baby via elective C-section. And I have an OB-GYN colleague who I was asking about this and reported directly to me that this happened. One of her patients came in and happened to test asymptomatically positive for COVID-19. So that admission became a hospitalization with COVID. So you have to question, is it really a good idea to test every patient? Now, why do they do that? Because they're concerned about the staff. They're concerned about quantifying the PPE, the personal protective equipment. So there's always two sides to a story, but you have to be very, very careful when you're making policy decisions based on that. So realizing we have maybe less staffed beds now because of the early, premature, prolonged shutdown, now we have an influx of patients. And we're trying to decide whether we're going to open up or shut down our entire economy based on available hospital beds. Well, we've shot ourselves in the foot twice. We've allowed ourselves to define more people as new cases, and we've started out with less staffed beds. So we've got a population of more sick people that were delayed. So now our ability to maintain 15% open beds is shot, particularly if you're in a county or a city like Bexar County, because as you know, our state is divided into, it's like A, B, C, D, E, F, G, trauma service areas. So in Bexar County, our county hospital, our university hospital, and just like Harris County and many of the major counties like Dallas County, and then down in the valley, et cetera, we cover in Bexar County 22 other counties. So if they have very, very sick COVID patients, they'll be sent to Bexar County. So Bexar County hospitalizations initially were not being broken down to show which were actually Bexar County residents. So here we are in Bexar County and they're saying, okay, you can no longer go to the parks. You cannot have people gather in groups of more than 100. Now we're taking a ding in Bexar County because we're accepting all these new patients and losing freedoms, whereas the other counties are sending the patients here, not reporting the deaths, and they're enjoying more personal and individual freedoms. So the way that we calculate data affects everyone's lives tremendously. And I must add one final thing about, we can talk about this in a minute, but the hospitals getting more money from HHS grants if it is recorded as a COVID hospitalization.
Right, and you had Dr. Redfield mention that in congressional testimony on Friday. The head of the CDC talked about this incentive. And I guess really when you think about it, this is one of those classic dilemmas, right? Because you talked about how hard these hospitals were hit by these restrictions that prevented them from generating income that could pay for doctors and nurses and other medical professionals. And in many cases, we saw layoffs all over the country. So they are suffering, and you want to do something to help make up the difference, given that the government is telling them that they can't do these procedures. And so you're right, they put in some additional payments, including, for example, 20% add-on for the Medicare reimbursements that are related to COVID. And then you've cited some additional bonus payments as well. And certainly it's resulted in some additional cases being reported, people who perhaps were in the hospital and instead of being there because of COVID, were simply there with COVID, as you mentioned, the elective C section with the person testing positive. I wanted to move on, though, to a different subject, and that's so far as what we know about the virus. And of course, viruses mutate, and this is a coronavirus, I guess a type of RNA virus similar to the common cold. So we're not entirely sure whether or not we're going to be able to develop lifelong immunity once being exposed to this virus. But could you tell us and walk us a bit through what you've seen both in South Dakota under Governor Kristi Noem, as well as in the nation of Sweden, and how they've dealt with this virus differently than, for example, other Western European states or other states here in the US?
Yes, and I think it's really important. This is where I kind of talk about, herd immunity versus herd mentality. And it's always shocking to me that this can be such a hot button point. But the human body is amazing, and we have a wonderful immunological system. And you have two types of cells, B cells and T cells, and you have antibodies that can be made to fight a virus. And antibodies are something that we've been testing for and looking at, and can also be reported as a positive test. But there's also a whole nother, and that's on kind of on the B cell immunity. There's also a whole nother set of immunity called T cell immunity. And this is extremely important. And we really don't have an accurate way to test for T cell immunity right now. So one of the ways that you develop immunity is by being out in the world, leading a normal life. None of us were born to be in a bubble. We were born to be out living life and taking risks and going to school and church and interacting. We're social people. So we are out in the community and we interact and we come in contact with a virus, and this stimulates our body to form antibodies or a T cell response. What's interesting about the coronavirus and COVID-2 seems to be related to the SARS and the coronavirus. They're very, very common in the cold. They're an RNA virus. They mutate very rapidly. They're very difficult to make a vaccine to because they mutate so rapidly. What we found out about this virus, which is really actually very comforting while we don't want to lose any lives whatsoever, is it seems to be particularly mild for children and young people. Once you hit about 61 and up, there's some risk stratified groups. It definitely preferentially hits our older patients. And this was exemplified in New York when, unfortunately, Governor Cuomo, I guess he didn't know, sent COVID patients of the elderly age back to their long-term care facilities and long to their nursing home facilities. And if you look at a great number of the lives lost in the United States of America, many of these were the older long-term care facility and nursing home patients sent back in New York, very tragically. Fortunately, by the time it got to Texas, we knew better than this and we learned from this experience. And so we can protect, traditionally what we want to do is we want to protect those at risk. We don't quarantine the healthy, and that's kind of what has happened. So what we've done really is this major lockdown of everyone in Texas. Let's talk about Texas. Let's talk about Bexar County, where I am. We've very, very much restricted people's activities. We shut schools down. People have been able to go to church, to funerals. My own father-in-law passed during this period of time, and we had to sit, 6 feet apart outdoors. We weren't able to invite friends. This takes a huge effect on people and ties back to what we talked about earlier, a lot of the collateral damage from the shutdown as far as overdoses and alcohol and suicides and all sorts of things. Whereas our young people, because with this virus, are very, very well protected. If you look at the death rate in children and people under 18, it's really like 0.000000. It's really statistically zero. So it's been a friendly virus to us, and we're out in the community, then we can form T cell immunity. I do think we need to have an ability to test for T cell immunity. We do have the ability to test for the antibodies, IgG, IgM, but there's a lot of people saying, well, the antibodies don't last long, or the antibodies, there's false positives, there's false negatives. But there's a role for everything, but maybe this is a unique virus where your antibodies do fade a little earlier, but you've developed T cell immunity. And that's what we all need, is we need this herd immunity. We need to be out interacting. And because if we all develop an immunity, then the virus kind of ends up dead ending. The natural history of viruses is that they kind of burn out. They don't ever completely go away, but more people have an immunity develop in their body that later when you encounter it, it can be triggered. Many people believe that those of us that possibly encountered coronaviruses in the past have certain little strands of those coronaviruses in our body that can be sparked when we encounter this new coronavirus. And maybe that's why this is such a mild virus in majority of people. And we can tell this by testing now. The majority of patients have very mild symptoms or no symptoms. Now, that is not to minimize the horrific toll that it can take on patients that are obese, diabetic, immunocompromised, over 60. And I think I have to have a shout out to our amazing physicians, particularly our critical care and pulmonary doctors in the hospitals that have learned and are doing a fabulous job. If you look at our death rate in Texas from COVID-19, it is really stellar. And in the face of not having increased our staffed beds, in the face of not having added a lot of more doctors, these doctors and nurses are working overtime. I mean, maybe instead of working 3 shifts a week, they're working 6. These people are working their fingers to the bone, particularly in, for example, Harris County, that truly is one of the really hot button counties hit hard right now. And then people down in the Rio Grande Valley, for example, and even in Bexar County, these doctors are working their fingers to the bone, and these nurses, but they're saving these patients. They're doing a beautiful job, but the majority of people are getting through this as outpatients.
Dr. Held, let me ask you one more question before we go to questions from the audience. And it's this: you mentioned the Rio Grande Valley and certainly the strain of the system from the Rio Grande Valley up to Bexar County. There's quite a bit of evidence that the medical system in Mexico, which wasn't particularly resilient to begin with, suffered a massive breakdown as the result of this virus. I know that the elected officials in Mexico made a conscious decision basically to ignore the virus. They told doctors and nurses not to wear personal protective equipment because it might spook the patients. And as a result, some of the older doctors and nurses did succumb. And my understanding is one of the largest nurses union in Mexico refused to even send their nurses to work for a while in protest. And so there's numerous media reports, not only in the major US media with CNN back in late June, but as well in both Spanish and English on both sides of the border, that suggests that large numbers of individuals, many of them gravely ill, some of them US nationals who happen to live in Mexico and work in the US, but many of them foreign nationals have come to the US seeking medical treatment. I know that in the Laredo area, regional trauma center, for a few days, late last week and into the weekend, they had no ICU beds available at all. And I think for the last couple of days, they were back up to 2. Have you seen or heard any information that would suggest that at least some portion of the cases, as well as the fatalities that we've experienced here in Texas, may have in fact originated in Mexico? And why is it that we can't get decent data that would quantify how hard we have been hit, what the magnitude of this cross-border traffic has been?
Again, this ties back to our wonderful, compassionate nature as Americans and as Texans to accept everyone and want to take care of them. But it's not a feasible goal to be able to take care of everyone in the world with the pandemic. I have seen in my own practice patients that are indeed, people that are, we kind of the repatriates that come over, and also patients that have second homes from Mexico that come and have families here. I've seen them as patients, and some are kind of just riding out the storm with their family and friends in San Antonio for one. But additionally, we've got to track this. We're neighbors. We're neighbors all along the valley, and that is very different in Texas than it is going to be in Florida. And we need to have ability when we're tracking this data, just like I was talking earlier about the ability to break down the data, looking at counties, when we're reporting deaths or hospitalizations in Bexar County, how many of those are Bexar County, how many are, Gillespie County, how many are another county, and how many are from Mexico. And we need to demand that data be analyzed. And we can tell that if we go through the hospitalizations, and certainly when we look at the deaths. The death rate is low, the death numbers are low, and I really believe that every death in every county needs to be scrutinized each day as to where that patient came from, what county, was it Texas, was it Mexico? And that needs to be absolutely broken out. Absolutely. Crucial issue and expensive.
Thank you. Well, let's go to the questions now. We have one question queued up and ready to go. Dr. Held, in your opinion, what's the most important metric that we should look at when it comes to reopening? And this is kind of a two-part, both society as a whole and specifically our schools.
Okay, so I believe that the schools should absolutely be open now. We have to have true data, as we discussed, and we can't really trust cases because of some of the issues we touched on earlier with the, antibody positive presumed cases. So then we have to look at either hospitalization numbers or the death numbers. And I think really clearly the death numbers are what we're going to have to look at, and we're going to have to break out COVID-related deaths to absolute COVID deaths. Sadly, when you do get $50,000 per diagnosis of COVID-related death, it needs to be broken out, and we need to individually look at those numbers. We also have to make sure that they're reported on the right day and not used to manipulate us. But you and I touched earlier on the numbers of excess deaths. We're down to 107%, and I think that that's an important number to look at too. But again, we have to take out the deaths that we caused. We have to take out the deaths that are the cases that were double and triple counted. So I think the number that we talked about the problems with even looking at available beds. If we want our available beds to go up, then we need to be building hospitals and beds, not just paying people to fill the beds that we've got. So I think we need to open up now, develop the herd immunity, protect our at-risk groups, and look at the death numbers county by county in Texas. And county, Loving County, or a county that's had no deaths, they should open. Harris County, every county is different. Every county is different.
So I know that this issue, certainly more than most of the issues surrounding the coronavirus, has been heavily politicized, and it's difficult to find information that is really reliable or that is not being driven by some agenda. But in your view, could you comment on the FDA, the Food and Drug Administration's current emergency use authorization for outpatient use of hydroxychloroquine?
I'm happy to comment on that. I think if you also look at what happened in mid-June that caused the numbers in Texas to start spiking, along with the increased definition, the very inclusive definition of what made a COVID case, along with the increased remuneration from HHS grants and from increased payment from commercial insurers and Medicare to increase case numbers. You also had somewhere around that period of time that they rescinded the emergency use authorization for hydroxychloroquine. There is broad evidence, and this has become extraordinarily controversial, but there is broad evidence across the world that patients who take very low dose hydroxychloroquine at the first sign of symptom, if they're in an at-risk group that we mentioned earlier, 61 and older, diabetic, obese, and in San Antonio and Bexar County, we have a lot of diabetes and a lot of obesity. If we could start these patients early as outpatients, we could prevent the hospitalizations from going up, and that has been very controversial and sadly peppered by intellectual dishonesty, scientific fraud, and even false data that caused articles to be retracted from two of the world's greatest medical journals, Lancet and New England Journal of Medicine. Sadly, those two articles were retracted, causing the World Health Organization then to respond. But you don't hear about that. You hear about the data that implicated hydroxychloroquine when it was given at very, very high toxic doses late in the game, late in hospitalized patients, where it's not useful. So sadly, that emergency use authorization was rescinded. And I think that sent the message to people. By that time, the use of hydroxychloroquine had been stigmatized and sabotaged, so that physicians did not feel comfortable prescribing it. And particularly with about 50% of physicians being employed now, I think that physicians fear retaliation or reprisal if they go against kind of what we talk about cookbook or protocol medicine. So about the same time that the numbers started going up in June 14th through 16th is about the time that probably outpatient hydroxychloroquine stopped being written. Now, as you'll recall, again, back to the governor's executive order, I sincerely thought when this started that this would be the perfect opportunity for us as physicians to write and get patients on zinc and hydroxychloroquine, because it's a known drug that we have. It's cheap, it's plentiful, it's shown to be a zinc ionophore that gets the zinc into the cell and fights and protects the lung and prevents the virus from replicating. And I thought this is going to be something that all physicians would be doing. And lo and behold, instead what happened was that, for example, even the Texas Board of Pharmacy came out with rules that were very prohibitive. And I have colleagues who are being investigated for writing hydroxychloroquine, which brings me back to your question. The Food and Drug Administration always has done safety. They've not always proven efficacy. And it is well known that the Food and Drug Administration says physicians must and are authorized and legally empowered to use drugs off-label. We use drugs off-label 20 to 30% of the time. And in fact, in some situations, we're forced to use drugs off-label because it saves money. And one example quickly is, if a patient has wet macular degeneration, there's 3 drugs: Avastin, Lucentis, and Eylea. Ophthalmologists are forced by commercial insurance and Medicare to use Avastin first because it's cheaper. It does not have an FDA indication for wet macular degeneration. The Lucentis and the Avastin do, but you're not allowed to use those. The Lucentis and Eylea do, but you're not allowed to use those until you fail the Avastin. So they're kind of speaking out of both sides of the mouth. Be very careful not using hydroxychloroquine because it doesn't have that approval, even though it's a 65-year-old drug that's extremely safe, that's been used for malaria around the world and seems to work at low doses, safe doses without problems. And yet on the other side of the coin, you're forced to use a drug off-label. So there's a lot of controversy. And I truly believe that physicians, it's between a patient and physician. And Redfield said this. And if your doctor and you decide that it's worth it for you to try the hydroxychloroquine, I think you should certainly have the ability to choose to do that. And a doctor should have the ability to choose to prescribe it without being fired or investigated by the medical and pharmacy board. So yeah, complex topic here.
Well, it certainly is nice to hear that Dr. Redfield, as the head of the CDC, came back to a bedrock principle, which is that government and elected officials probably shouldn't be getting between their patients and their doctors. I think that we could probably agree on that, right?
I really do. And I think this shows that so clearly.
So I don't know as if there's any evidence yet conclusively that this COVID-19 virus is going to follow any sort of a seasonal pattern. I know we certainly see that with influenza. But here we are now at the beginning of August. Influenza season is going to start cranking up again in parts of the U.S. In September next month? Could it be that soon? Really already? What do we expect as we do head into the fall flu season, though? Do you think that there could be another nationwide shutdown in the offing as people are now perhaps more aware and more fearful of viruses than they have been in the past?
Well, we are going to have the flu. COVID is not all of a sudden COVID is not a cure for the flu. We're going to have the flu and we're going to have COVID. We know we will. And so again, it's going to be extremely important to look, like we were talking about earlier, what are the COVID cases and what are excess deaths and what is flu. And if you look at the curves, we're probably really going to have it. But I think what we've learned, we didn't talk about Sweden enough earlier that didn't shut down. We didn't talk about South Dakota that didn't shut down. I think what we've learned from this is we shouldn't shut down. We've created additional problems. We've stressed the system, and we're going to have flu. We need to do the flu test, see what it is, and sort it out from a scientific standpoint. Again, our numbers need to be meaningful, not means of manipulation. And we're going to have it, be ready. But you don't quarantine everyone in the United States and we all go under a rock for the rest of our lives. We cannot lock down again. Cannot.
So next question. This has to do with guidelines regarding school and churches, going to church and other public events. In your opinion, as you look at how these things are created and enforced, do you see the local government, the state government, or federal government as really the entity that should be taking the lead? And then, if I can, to follow up on that, it seems like there's a lot of inconsistency when there are guidelines put in place. For example, we're told we can't go to the park or we can't go to church, but if we're out protesting against the proper thing to protest on, then we get a pass. Or if we're going to pack into a church for the memorial service for a revered civil rights icon, in the case of Congressman Lewis, then again, you get a pass, right? So first of all, should guidelines as far as our public life, what level of government should they be set at? And do you have an issue with this seeming inconsistency in their enforcement?
Yes, on all those. So first of all, guidelines are guidelines. They are not mandates. And people have construed CDC guidelines. I think that and this is why your politician, your bureaucrat is not your doctor. And when they try to be, that's when we have problems. So things should really start at the most intimate and local level, and that's between you and your family and your loved ones and your doctor. Beyond that, then it should go to the very local level, your city, your county, and then I'm on up to state agencies, and finally, ultimately, up to the federal level. I mean, we are a constitutional republic, and the smaller, the better, because who knows better what's going on in their community. And as we said, there's a lot of a difference between what's going on in the Rio Grande Valley because of where they are geographically and other counties in Texas. So local is what I believe with. Sadly, that's become very political. Guidelines are guidelines, they're not mandates. And how sad that people say you should mask. The very same people that say you should go out and protest are the ones that say you shouldn't go back to school. It's very tragic, and we've got to be honest with ourselves. Even Dr. Fauci, what a disappointment when Jim Jordan was questioning him about this, to say, is this virus, why can you protest, and where does that come into play? Along the lines of the EUA being taken away and the new definitions of COVID and the payment for COVID. You do certain things from a policy standpoint, and you can create the appearance of a horrible pandemic. So we need to be consistent. We need to be honest with ourselves. And if you're sick and you're around other people, this is catching, wear your mask. If you're outside, don't wear your mask in your car. Go to church, go to school. We need to be, those are the sorts of things that the policy people need to be doing, getting people educated, not deciding when and where, and what you should take between a patient and a doctor.
So you mentioned masks. Let's talk a bit about that. There's a lot of discussion over masks and their mandates. I know that some jurisdictions in Texas and around the country are looking at things like fines, some of them pretty substantial, if people are out in public not wearing a mask. first of all, tell us a bit about the science, the medical fact about wearing, for example, an N95 mask. What exactly does that do? And you know, if you were to be running the show, what would you say on masks as to when and where they should be worn?
Well, you know, we could do a whole day on masks. It's a fascinating topic, and viruses are very, very, very small. They can be, and it depends also on the way that a virus is transmitted. Is it a respiratory virus? Is it in your speech? Is it in your breath? Is it in your droplets, in your cough? If it is, then you need to consider wearing a mask. But we know that the size of the mask, and you know, the size of the mask and the way it fits determines whether that viral particle is going to penetrate that barrier to get through to you. For example, when I'm in the OR and I wear a mask, that's not going to stop. The little surgical masks you see everyone wearing, that doesn't stop the virus. Cloth masks don't stop the virus. But what they do stop is they stop large droplets. When you're speaking, if you're spraying something out, if you're coughing. Some people, however, say, well, but if you wipe your arm and then you're spreading the virus more. But we do know that if you're in very, very, very close proximity within 6 feet, and I don't even know that that's a magic number, but people have looked at that, then it behooves you, particularly if you're in a high-risk group, to wear the mask. I wear masks when I'm seeing my patients in the office because I'm close to them. So they have on a mask, I have on a mask, I have a plastic shield between us. When I'm in the OR, I'm wearing a mask. But again, we need to be sensible. And I'm really opposed to mandates and fines for anything. You know, I laugh and say, if we were humans, if we were supposed to wear a mask, we would have been born, you know, with a flap of skin or some way to put that down. We need to be smart. We need to separate. You know, if someone has diarrhea, if someone has a GI problem, if someone has any sort of infection, we don't go hang around them. We don't go protest with them. If you feel bad, stay home. But we don't suddenly, everyone starts masking. And I think that's what people resent is the sign of the mask, the depersonalization, the inability to see human emotion. Imagine children trying to go to school and not being able to see the emotion on one another's face and the teachers. So I believe in masks in close proximity right now with the coronavirus. I do not believe, I do not like the term the new normal. We should never accept full-time mask wearing. We can do better than that. With 2020 science, we can do better. And I try to leave the counties. As soon as I leave my office, I try to go somewhere where I do not wear a mask and try to stay in a situation where I do not have to wear a mask and try to go to a county or city where I do not. And sadly, as much as I love San Antonio and Bexar County, you know, these are the sorts of counties that are going to be more totalitarian, if you will, in their approach than others.
So final question, let's talk a bit about proportion and about the economic effect of this pandemic. If you look at the Congress's response to the pandemic, as well as the larger economy, we're looking at somewhere north of $2 trillion, maybe $3 trillion, $4 trillion, that it's cost our economy, not to mention, of course, children not learning, many restaurants that will never survive and have been shut down permanently. If you were to go back and look at, for example, the last similar pandemic, it would have been in the year 1968, 69. We had a little thing going on at the time called the Vietnam War. We had protests. But as I recall, if you look at the proportion of the size of the country back then and scale it up to where we are now, we probably lost, more than 250,000 people proportionately. And then if you go back, another 10 or 15 years, there was another epidemic at that time. I think that it was the Asian and the Hong Kong flu. I'm trying to remember exactly what they were called. But other than a few isolated school shutdowns where parents took it upon themselves to keep their children back from school, there really wasn't any sort of a large-scale government response back then. And yet in both of those instances, proportionately, far more people died from those than today. So again, I know that hindsight is 2020, and we didn't quite know what we were dealing with, partially due to a lot of misinformation from China. But what would you think we should do if this were to happen, let's say every 5 years? I mean, I doubt the country could afford it.
The country can afford it, and it really breaks my heart. I never thought I would ever see us in this situation within our lifetimes, as most of us never did. Yes, we were misled by China, but we should have known that. Number one, and as I said, if we're going to be participating in experimentation and viral manipulation to try to find a cure, we need to be very careful to be able to deal with the consequences thereof if anything should happen as a result of that endeavor. The other thing is, we have lost so much and gained so little. And I think that's, again, because of the statistics. When we were told initially that we would lose 2 million people by really bad statistical analysis coming out of London. If we look more at some of the stats coming out of Washington, they're more in line with what we're seeing. I don't want to be too hard on Dr. Fauci, but he has been a bureaucrat up there in Washington, D.C. since 1984. And if I do the math, isn't that about 36 years? And if I do the math, I know that his budget this year in 2020 was $5.5 billion. I know that in 2017, it was $4.5 billion. So I extrapolate in there, just over the last 4 to 5 years, he's probably had $25 billion in just his very small institute within the NIH, which is under HHS, billions of dollars. He was charged with pandemic preparedness. He's in charge of all of this, and he wasn't prepared. We were not prepared. I'm sorry, but if you took that $25 billion over the last 5 years and you know what you're doing and you know what's going on and you've been there 34 years, you've got to do better than that. And we have enough brain power and ingenuity in the United States of America that if we free it up, we can find a cure, we can fix this. And I'm optimistic. Just let us repurpose what we've got. Let us repurpose the plasma. How about the convalescent plasma? How about ivermectin? How about hydroxychloroquine? Those are old things we have. That's just using what we've got, and then unleash our ingenuity and let us do things. I mean, I think, God bless him. He's been there forever. He's 79, 80 years old. He's an icon, but he needs a new spot, and we need a new person in there. And I'm very sad. This was an experiment. Let's learn from it. Let's never, ever lock down again, ever. And in New York, if you're going to live in New York, I always say, if you live in South Texas, you better have your snake boots. And if you live in New York and you're going to live amidst that many people, you better have your PPE and close your vents and have ways to kill viruses, have UV in your room, have some sort of, HEPA filters in the AC units. Those are old systems. Let's update our public health systems and do things. We cannot shut down this is almost like crimes against humanity, what we've done to our freedom, our liberties, our country, our money, our economy, and our people.
Well, thank you, Dr. Held. That's a great way to end our time together. Thank you for your time. Thank you for your service to the people of Texas with your ophthalmologic practice and the surgeries that you perform. I certainly hope that you get back into the surgery room with great frequency now after that 2 or 3 month layoff. Certainly people's eyes weren't getting any better in that time period. So again, thank you for your service to the people of the great state of Texas. And for those of you watching across Texas and America, thank you for your time viewing this most recent live stream from the Texas Public Policy Foundation. I'm Chuck DeVore. Thank you for spending your time with us.